I'm Heather Wakelee, Professor of Medicine and Chief of the Division of Medical Oncology at Stanford University, Deputy Director of the Stanford Cancer Institute, and currently the President of the International Association for the Study of Lung Cancer, and really excited to be here and doing this year in review webinar on non-targeted treatment of lung cancer, non-small cell lung cancer. Lots happening in that field. So as you can see, there are a lot of trials that I will be talking about. There's a lot happening, especially around immune therapy, antibody drug conjugates in particular. So what was really exciting in the past year are getting these 5-year and other long-term outcomes from trials. When I started as a medical oncologist and we talked about metastatic disease, we did not talk about 5-year survival. That was just not something that was part of our discussion. I mean, we all knew 1 or 2 patients, but it just wasn't a common discussion point. And now, as we are getting to the time period where the immune checkpoint inhibitor trials are reading out at that 5-year mark, we have a lot of trials where we have this 5-year data. And to me, that's one of the most hopeful things that we can offer our patients as we talk about them. So this is the long-term follow-up data, 5-year from Keynote-042. For the audience, of course, this was a study that enrolled patients with any PD-L1 positivity in their tumor to receive pembrolizumab versus chemotherapy. The first study, the Keynote-024, was only in those with high PD-L1 expression of at least 50%. This now was a broader group. And there's a little bit more controversy around this trial. Again, we saw that the most benefit was in those whose tumor expression was at least 50%. But there was some benefit in those with 1 to 49%. How the study was presented initially, it was the greater than 1% and then greater than 50%, and not as much focused on just that 1 to 49%. And we see in this presentation also it's greater than 1%, greater than 20%, greater than 50%. So you've got that greater than 50% group sort of pulling positivity throughout the whole thing. But it's still very, very strikingly positive trial. And we see here a long-term benefit. And we're seeing this 20% overall survival at 5 years. And that 20% 5-year survival is something that we see pretty consistently across multiple trials of the checkpoint inhibitors, where there's this subset of patients, somewhere around 20%, whose tumors are very sensitive and they have these durable responses. And so this was another study demonstrating that. And we do see that most of the benefit is in those patients who do have high PD-L1 expression. So when we look at that 5-year survival and the patients who are surviving, in the high PD-L1 group, it's 22%, greater than 20%, 19%, greater than 1%, 16, 17%. And so what it would be like in just the 1 to 49, we don't have that presentation, but we know it's going to be a little bit lower. But I think this is really important as we think about that long-term response, long-term benefit. And we'll get into some later trials with long-term data looking specifically at these patients who are these long-term benefiting folks. So it's a busy slide, but I think that key point is illustrated well here. So then we go on to another study. We have many PD-1, PD-L1 checkpoint inhibitors. Cemiplimab, a lot of data coming out with cemiplimab. So this was a presentation at ESMO in 2022, 3-year survival with cemiplimab plus chemo versus chemo alone. It's titled as a continuation of cemiplimab beyond progression with adding the chemo. But if you look at this trial design in more detail, Arm A is cemiplimab and Arm B is chemo. In the Arm A, which is the cemiplimab monotherapy, at the time of progression, you can continue the drug and then you add chemo at the time of progression. For those who got chemo, they do have an optional crossover to get the cemiplimab. So everybody's able to get the drug. And the question is, if you start with immune therapy, and adding chemotherapy to it, the benefit of that versus starting with chemo and then switching over to cemiplimab. And this was a trial that was only in patients with high PD-L1 expression, so greater than 50%. And so this sort of supports, it's like Keynote 024, where that was only in the 50%. And again, it was single agent checkpoint inhibitor versus chemo. The difference here is they were allowed to continue the cemiplimab at progression and add the chemo to it. And so they emphasize that outcome in this presentation. And you can see here that 3-year overall survival, those curves are beautifully separating, very clear positivity for overall survival. Progression-free survival, that separation happened more around the 6-month mark. And the patients on chemotherapy, of course, stopped treatment after they completed the chemotherapy. So this is not too surprising in and of itself. Another trial showing single agent checkpoint inhibitor better than chemotherapy when you have high PD-L1 expression in the tumor. What they also presented was this other analysis, which gets very complicated, looking at this period 1, period 2. Period 1 was either cemiplimab or chemo. Period 2 was at the time of progression. So continuing cemiplimab, adding chemo, or if you were on chemo, getting cemiplimab. And it just shows that you can get a second response when you add the chemo to ongoing cemiplimab, just like you can get a response if you weren't on a checkpoint inhibitor and you started chemo. So this study is another positive trial. We've got 3-year data now confirming that single agent checkpoint inhibitor, in this case cemiplimab, is great. If you have high PD-L1, better than chemo. If you're on cemiplimab and you add chemo to it, you're going to get a benefit, but whether that's from the combo or just would have happened with chemo alone, we don't really get from this particular study. Still, a good positive trial, another long-term benefit with checkpoint inhibitor data study. And now, this is a slightly different study. Most of what I'm going to talk about today focuses on the checkpoint inhibitors. This one does also, but this is a different twist on things. Instead of giving immune checkpoint inhibitors intravenously, this is a new subcutaneous formulation of atezolizumab. And I thought this study was really interesting because when we think about the challenges we face as oncologists treating our patients, having them have to come in every 2 weeks, 3 weeks, 4 weeks, 6 weeks to get infusions can be really difficult. We know that the costs are high for patients. And sometimes there's a bit of a higher risk of immune-related adverse events when you're getting an IV infusion versus a subcutaneous injection. So this trial was a head-to-head comparison of sub-Q atezo versus IV atezo. And if you look, there's a lot of details in this, but essentially they showed that you weren't getting much of a difference as far as adverse events. And the efficacy, at least as they looked at this kind of early on efficacy, was very similar. These were not patients who necessarily had high PD-L1 expression, so response rates are a little lower, in that 10% range that we see sort of in an unselected patient population, but very similar. And to me, this was important because the subcutaneous option has the promise of reduced cost, option for home administration, and broader distribution opportunities. So I think it was pretty exciting for that reason. And I'll pause there and see if you've got any comments on that, Neil.
Yeah, I'm just curious because I don't remember hearing very much about sub-Q IOs. I mean, obviously they're extremely commonly used in so many. Seems like it would be a gigantic, benefit. Is it being looked at with other IOs?
So where I'm most familiar with it is actually with one of the bispecific amivantamab, and so we're working on a trial with that where one of its biggest issues is the infusion reactions. I haven't heard much, and I mean, I'll be honest, I didn't hear much about this study when it was presented at the ESMO IO conference in December. And so I think it's really important though, we focus on what's the newest and latest drug and mechanism of action and long-term outcomes. But from a practical standpoint, this has the potential to be more practice changing by bringing this different mechanism of administration.
Yeah, I mean, really could change the face of the infusion rooms in general, not just lung cancer.
Right.
Interesting.
Yeah, it's pretty exciting.
Please continue.
Okay, so back to our theme of long-term outcomes. So this is the 5-year survival data from Keynote 189. So this, of course, was chemo plus pembrolizumab. And we see that the overall survival separation continues out, progression-free survival continues out into that 5-year time period. This was a study where PD-L1 levels did matter, not as much as with the single agents, but still was important. One of the things they emphasized in this presentation I thought was a little bit disingenuous because they looked at, for those patients who were still doing well, how well did they do? And I think we need to be careful when we select out the survivor bias here, but still really exciting to see as we are talking to patients who are just about to start on treatment with this combination of platinum, pemetrexed, and pembrolizumab, which is still very widely used, to be able to look people in the eye and say, there's a chance that you are going to be living 5 years from now, potentially without evidence of disease. We're back to that somewhere around 20% number. And this is highlighting that on this swimmer's plot. You see the dark gray bars are the time that patients were on treatment, continuation with the pembrolizumab maintenance. The little black dots are when people progressed, and you see that there are some patients who stayed on after initial progression. But you also see that the light gray is once treatment has been stopped and patients are followed. And there are a number of patients here who, once their pembrolizumab was stopped, they haven't had any evidence of disease recurrence, and now we're at 5 years. We still are cautious with the cure word, but this is the kind of situation where you think about it. I think it is notable that there were some patients who did have progression at the 3-year mark, at the 4-year mark, but it's pretty small numbers. And the majority of patients that have made it out beyond 3 years, most of those patients don't have any later progression events, but we still need to be mindful. So one of the big debates we have right now is whether to stop at 2 years or not, and what do you do when they recur if you have stopped. This is an area where we don't have any data we're talking about today, but I think this is where ctDNA and other ways of looking for that minimal residual disease will be really important. And maybe we don't even need to go 2 years. Maybe there's some patients where after 6 months or a year, they have no residual tumor. We can look with new assays that are being developed to be able to be comfortable saying, and now we can stop, but we'll keep checking to make sure that nothing comes back. And for this situation here, maybe if we do go to 2 years, if we had a way to figure out who are those patients who are in the top bar where they never get the black dot, and who are the patients who aren't. And so I think this is really important development that's being done. So here we have, that duration of response going out quite a ways, 60 months or so, and continuing. The 3-year rate after completing the 35-year cycles is 72%. So they're essentially saying that if you make it to 2 years and then you stop, you've got a really high chance that you'll still be doing okay at 3 years. Though some of these patients have, of course, restarted treatment. So I'll pause there, Neil, see if you have any comments you wanted to make.
Yeah, I was just flashing on this case. We're actually presenting a bunch of cases this weekend at the SGO meeting. One was MSI high metastatic endometrial cancer. A patient was on Pembro, was coming to the 2-year point. They were talking about whether to stop or not, and then, of course, she recurred. What I was going to ask you is, have you done, or are people doing ctDNA? Do you see it at 2 years or 5 years? Have you ever done it?
We're not doing it in routine practice at this time, but I work closely with Max Dean, and so we're always doing all sorts of ctDNA studies and analyses. And this is one of the questions we have looked at, and we've had some publications on it, but it's not a routinely done yet. But I think that's where we're heading. It's going to be a really important question.
But I mean, do you see patients who have positive ctDNAs like after 2 years?
Well, I don't have a series of patients in my mind I can think of where I've actually looked at it, because we're still mostly doing it within the context of research. So we don't have the
Right.
and your patient still has it. It's more of a still trying to gather that data and understand what it means. My assumption, if we look at this trial data, the patients who have the black dot, who have recurred, they probably all did if you could have an assay that was sensitive and specific enough. And that's where we're still challenged. I don't think any of the commercial assays that are out there right now are sensitive and specific enough for us to be comfortable saying, and you don't have it and you can stop. We can say, they're sensitive enough to say, and you still have it and you probably shouldn't stop. But that being able to stop comfortably, we're not quite there, but that's what we're working towards.
Interesting. Please continue.
Okay, so this is a very parallel. This is the Keynote 407, chemo plus Pembro, or chemo plus or minus Pembro, but in the squamous cell histology, very, very similar results. And, as we go through that, you see the robustness of that separation isn't quite as strong, and where we've had the adenocarcinoma or the non-squamous and the squamous, pretty much uniformly, the trials that we're looking at squamous cell histology patients, that we weren't seeing as much benefit, but still benefit statistically significant is standard of care. But there seems to be a higher benefit for whatever reason in the non-squamous, another mystery to resolve. Very similar analysis, of course, same company, same pembrolizumab, same idea. If you get to 2 years and then you stop, there are a large number of patients who never have recurrence, but some who do even as much as 2 years after they've stopped. And so this is, again, very encouraging. It's not the majority of patients. It's, 10, 20%, but that 20% number keeps coming up. But it's real hope for patients. And where we're working now is trying to figure out who needs more than just single agent checkpoint inhibitor, and we'll get to some of those discussions later. When can we safely stop? When do we need to continue? But very, very hopeful time. Okay, now we've been talking about the pembrolizumab data. Now we're back to cemiplimab. So this is cemiplimab plus chemo versus chemo alone. So same idea as the two we just went through with Pembro. This was a phase 3 trial. It was actually published in Nature Medicine in 2022. I kind of look at this as another positive chemo plus immune checkpoint inhibitor trial. In this case, PD-L1 levels were important. We see that with these pink and blue bars that we're looking at response rates. And you can see that that was higher in the combination versus with the chemotherapy alone. And that, we go from left was no PD-L1 expression, right is that high PD-L1 expression. The blue bar, which is the chemo alone, doesn't vary that much. The pink bar goes up, higher PD-L1, more likelihood of having response. So that's that additional benefit of adding the cemiplimab. And we see in the curves both overall survival and progression-free survival benefit. So positive trial, 3-year data here looking good. Another 5-year data. This is the nivolumab plus nivolumab, ipilimumab versus chemo, the Checkmate 227. Again, very complex trial design. They had divided patients up into those without PD-L1 expression in their tumor and with PD-L1 expression in their tumor. Then they had 3 different groups randomized for each of those. Some were the same, some were variable. And so Nivo plus chemo for those who had less than PD-L1 expression, chemo alone, or Nivo alone for those with higher, Nivo Ipi option in both situations, and then combinations. And so when we try to look at this trial, it gets very, very complex. But I think the take home is that for patients who did have PD-L1 expression, when we look at those getting Nivo Ipi versus chemotherapy, because that was in both of the arms, you could get Nivo Ipi and you could get chemo. Overall survival 24% versus 14% for Nivo Ipi versus chemo if there was PD-L1 expression. If there was no PD-L1 expression, you still had a benefit with the checkpoint inhibitor. And this is where we bring in the question of, okay, we've talked about checkpoint PD-L1 alone, where it was very PD-L1 dependent. When you bring in the CTLA-4 inhibitor, that PD-L1 doesn't seem to matter as much. If you look at sort of the overall benefit in the greater than 1%, that 24% versus 14%, those numbers are both higher than what we get in the low PD-L1 group, but that magnitude of difference between them is actually about the same, if not even more so. And so this concept that by adding in CTLA-4 to a PD-1 inhibitor in this case, you can sort of overcome that lack of PD-L1 expression, which has limited benefit for patients with those sorts of tumors with checkpoint inhibitor alone. It gets a little bit confusing. Sort of my take home from it is nivolumab, ipilimumab is a reasonable option for patients versus chemotherapy, and that is a reasonable option regardless of PD-L1 expression. When I talk about giving single agent checkpoint inhibitors to patients, I am very uncomfortable with that strategy for patients whose tumors don't have PD-L1 expression. So adding in the CTLA-4 seems to make a difference. I did not arrive at that conclusion quickly. It took me a while and a lot of trials to kind of get there, but as we go through this study in Poseidon, I think most of the folks listening to this will also see that seems to be a recurring pattern. I like to look at things as it's more likely to be a truth if we're seeing the same thing showing up in multiple trials. And we get a lot of flukes, especially when we're looking at what does PD-L1 level mean with the various drugs. We've had a lot of things that didn't always make sense, but if you've got consistent patterns, that's more likely to be truth. And I'm now convinced that this combination CTLA-4, PD-1 or PD-L1 combination does seem to overcome some of the inherent resistance we get in the non-PD-L1 expressing tumors. So that's something that I've more recently come to, and this trial is showing that clearly. We're also seeing this about 20% long-term survival at 5 years, which is great. In this case with the nivo-ipi, and this is seen again, and the benefit is seen regardless of PD-L1 in this trial. So this study is also important to note that about 2/3 of these long-term survivors are completely off trial, similar to what we were seeing with the single agent pembrolizumab in the studies with patients who had higher PD-L1 expression. Okay, that was a mouthful on that one. So now we're going to talk about Luis Pazarez's study. He'll be in this session, he's talking about the early stage and I'm talking about late stage. And so we're each talking about each other's data, which is good, I'm sure. So you get different perspectives. But this is Luis's presentation from Checkmate 9 LA. This was the updated ASCO 2022. And again, showing that this is a strongly positive trial, long-term benefit seen, and this is 3-year data. Overall survival at 3 years is 27%, probably tracking to be close to that 20% at 5 years we keep running into. And here, again, with the combination of CTLA-4 and PD-1, you see the benefit in patients even in tumors where there is no PD-L1 expression. And so what I've highlighted on this slide are the separation, overall survival benefit, PFS benefit, and then in this forest plot here, I've highlighted in the red box that these benefits are seen regardless of PD-L1 expression. So that really didn't matter when you've added in the ipilimumab to the nivolumab. Now we move to Poseidon. So another combination PD-L1, CTLA-4, so durvalumab with tremelimumab in this trial. And this trial was not as overall robustly positive in all of the arms as we were initially expecting to see, but in the end definitely has some positivity to it, and I think adds very clearly to this story now that adding the CTLA-4 can overcome the resistance that we see to single agent checkpoint, PD-1, PD-L1 checkpoint inhibitors in tumors without PD-L1 expression on the tumor. So this was a study enrolled patients with metastatic stage 4 disease, no known EGFR mutation or ALK translocation, no prior treatment, and then they were randomized 1:1:1 to durvalumab, PD-L1 plus chemotherapy, to durvalumab plus tremelimumab, the CTLA-4 agent, plus chemo, or to chemo alone. And when we look in the durvalumab plus chemo versus chemo, both the progression-free and overall survival, that overall survival was not positive. And that was one of the things about this trial where people were like, that doesn't make as much, doesn't kind of fit with the whole story. But when we look at the 4-drug, because you had 2 chemo drugs, so durva, tremi, chemo, here that progression-free survival benefit is a little bit more robust. And that overall survival hazard ratio is also positive at 0.77. So this is a positive trial. And we also see that when we look at those PD-L1 expressions there at the bottom, you can see that it actually did matter when we're looking at the durvalumab alone versus chemo, but it didn't matter when you added in the tremelimumab. So again, this consistent story. And again, consistent long-term benefit here, 3 years, 27%. We'll see what we get to at 5 years. A little bit more on this. This is the overall survival in a bit more detail. 4-drug regimen at 4 years now, we're down to about 21% versus 16% with Durva alone. But Durva plus Tremi increased benefit over that long-term period. And again, we're at about 20% now at 4 years with the Durva Tremi combination. And again, the PD-L1 didn't seem to matter once we add in that CTLA-4 drug. So this was an ESMO presentation in 2022. Now on to our antibody drug conjugate. So this is Tropion-Lung02. This is the Dapopotamab deruxtecan, our Dato-DXd, plus Pembro, plus or minus chemo with a platinum agent added in. And I think it's important when we talk about the antibody drug conjugates, they are still chemo. I think a lot of patients, when they hear about these, oh, it's a new drug, it's going to be like immunotherapy. It is still chemo. We still have our chemo side effects plus some. But with many of these agents, we do get those higher response rates when we're actually hitting a clear target. So this is a TROP2 IgG monoclonal antibody with deruxtecan, which is a topoisomerase 1 inhibitor. That deruxtecan payload has what we're seeing in a lot of the most active antibody drug conjugates. So I do like the deruxtecan as far as what we've been seeing. And here this was looking at a combination of either pembrolizumab plus Dato-DXd or those two with the addition of platinum. And what's interesting is that we're not seeing much benefit with the addition of platinum. So when you look at the dosing for these doublets versus triplets, the patients were relatively well balanced. Difference being those getting the triplet couldn't have had other prior platinum treatment, and those getting the doublet could have had prior treatment. And we'll look at the the balance by PD-L1 and all those things, so that's not as relevant. And when we look at these responses, we see that the response rate was actually reasonably high. With just the doublet, it was 62%. With the triplet, only 50%. Using extreme caution with those numbers. When you've only got 13 to 20 patients, 1 or 2 patients difference in response can hugely change those responses. So I try not to quote that too much. But at least the first signal was that adding in the platinum wasn't doing a whole lot other than adding toxicity. And so they're actually planning to move forward with just the Dato-DXd plus the pembrolizumab, which is interesting when we haven't been bold enough to try peeling back the platinum in a lot of our other prior trials. So we'll see how this pans out. There's a phase 3 trial, the Tropion-Lung08 trial, which is ongoing, and that's the Dato-DXd plus Pembro versus Pembro alone for first-line treatment in patients with high PD-L1 expression. So we'll see how that pans out. Again, these drugs are not without toxicity. We need to be very cautious in knowing about those toxicities and monitoring closely. Okay, another antibody drug conjugate. This time is to cemitamab, Ravtensin, so a different linker and a different payload. This is in patients with non-squamous histology, and this is the CEA, antigen-related cell adhesion molecule 5, so CEACAM5. That is what we're trying to target. And this was a presentation at ASCO of 2022. As you can see, it's a very complex drug. You've got your antibody, you've got your toxin attached to it. In the initial trial, the phase 1/2 study with this compound, there was some activity in heavily pretreated patients. And they were trying to look at the CEACAM5 expression as a way of selecting higher response, lower response. So in the higher responding patients, 20% had a response. In those with moderate expression, the response rates were much lower. And so there does seem to be some selection. One of the challenges I personally have had in looking at all the ADC data is that for some of the ADCs, they're not really as targeted. You know, we have some like the trastuzumab deruxtecan that is clearly a targeted agent. In patients with a HER2 mutation, our response rates are 60, 70%. But then you've got some of these other antibody drug conjugates where when your response rates are only in that 20% range, you wonder, is that really a target, or is that just we can get 20% single agent chemo response rates as well? And so then I think about that as fancy chemo versus a targeted agent. And so this is differentially active based on the CEACAM5 expression. And so it's somewhat targeted, but it's not like a super robust targeted response is how I'm looking at it. Still reasonable to look at. And what they were highlighting here is that of the patients who responded, some had pretty durable responses. And so I think that is worthy of note and is certainly reasonable to look at it. I think when we're trying to assess drug efficacy, we look at what's the response rate, but that duration of response is also really important. Because if everybody responds for a month, that's not very useful. It only gives people a very short time. An ideal drug is working for everybody and forever, right? We don't quite have that. But if something doesn't work it only works in 10 to 20% of patients, but in that 10 to 20%, it works for multiple years, that's still a really important thing to find. So we'll see how this pans out. And Neil, did you want to comment on this?
Yeah, just maybe you can talk a little bit about what CEACAM actually is. And this may be a very naive, stupid question, but does it have anything to do with CEA?
Yeah, it does. So CEA this is just a marker that we find in cancers. It's sometimes shed, right? And so it's a protein that we can measure, and CEA can be like a relatively non-specific tumor marker that we can look at tumor expression. Instead of doing imaging, sometimes we can follow those CEA levels.
Is that what this is targeting, though? Is it targeting CEA?
It's a different molecule, but it's the CEA-related adhesion molecule, so it's in that same pathway. And I would have to go back to my biochemistry book to give you a better answer than that. So,
interesting. Yeah, no, I never heard of this until I saw this paper in there, but it looks really interesting. No unusual side effects. I don't know this payload. I'm not sure what that is. Any particular side effects you see with it?
So I haven't used this compound myself as much. I think that the things we need to be watching for, we have a lot of issues with all of these, with a lot of the ADCs. There's ocular toxicity. I don't know about it. With this one, there is some risk there.
Oh, really?
There are issues with edema, infusion reactions, and then traditional chemotherapy toxicities, nausea, hair loss, those sorts of things. And I can get back to you on the specifics with this drug more.
Yeah, no, I can. So. Yeah, we can even talk about it in the webinar. Yeah. No, I mean there are more and more ADCs that we're running into with ocular toxicity. So I was curious about that, but not in lung cancer yet. But yeah, myeloma, bladder cancer, et cetera.
Yeah.
All right, please continue.
And this is then another study. This is Hudson, and this is an umbrella study. So this is looking at multiple different drugs, biomarker-directed phase 2 platform. And really what it is looking at is adding durvalumab to these other targeted drugs. And so far what this data has looked at is with these 4 compounds, is ceralasertib, which is an ATR inhibitor, danvatirsen, which is a STAT3 inhibitor, olaparib, which is a PARP inhibitor, or oleclumab, which is an anti-CD73 monoclonal antibody. Don't worry about memorizing all of those. The only one you really need to know about is the ceralasertib, which was the ATR inhibitor. That was the only positive aspect of this trial so far. And I'll show you that on this next slide, where you see that they enrolled pretty well. It was close to 60 patients in each of the arms, a few more in the olaparib arm. The response rates were not super robust, but it was 17% with the durva plus ceralasertib, and these were all pretreated patients. The others really almost no responses. And we see that when we look at the progression-free as well as overall survival. There was a benefit, it seems, in the Durva plus the ceralasertib, but not with the other arms. And so they're going to be moving forward with the durvalumab and ceralasertib that showed promising activity. And then they'll be looking at other drugs that can be brought into this umbrella platform. Another sort of novel approach. So this is a tumor treating fields device. It's a wearable thing that patients put on. There's a vest for brain tumors. This is where it's already widely utilized. It's a cap that they put on. And it basically uses these pulse electrical fields, in this case combined with pembrolizumab for advanced lung cancer. And so again, the tumor treating fields, it's an anti-mitotic treatment with these pulse fields. It's already approved in glioblastoma. It's already approved in mesothelioma with the vest. And this was an open label trial. It was randomized, looking at the fields in combination with checkpoint inhibitors or with docetaxel versus the immune checkpoint inhibitor or docetaxel alone. And I don't have all the slides, but basically what they've presented so far is just this press release. We haven't seen all of the data, but in the press release, it showed a significant and meaningful overall survival benefit with the tumor treatment fields plus immune therapy versus immune therapy alone. In the docetaxel plus or minus the TTF fields, that had a trend but was not overall positive. And it's well tolerated. So we're waiting to see a bit more data. There is a study, this Keynote B36, which is a phase 2 study looking at the tumor treatment fields plus pembro for first-line treatment, where we've seen a little bit of that data already, and that's where they went with this phase 3. And so we will see more soon, and that's all we know. So I don't know if patients are going to be accepting of this because they're actually having to wear a device versus getting an infusion. It has been widely adopted in brain tumors, and patients do use those. I don't think we've had very much adoption yet for mesothelioma. And so we'll just have to wait and see what happens. And I think how positive is a positive result, that's going to be really important as we try to make those determinations. So do you have a comment on that one?
Yeah, we're actually having a couple cases presented again at the SGO of trial in ovarian cancer. And there, both of the patients that were presenting had significant dermatologic toxicities. And I know that you said you haven't used it, but have you heard anything? Do you know anything about to what extent skin is a problem, where the things that you put on cause irritation?
I haven't heard that, but I will confess I don't have a lot of familiarity with this technology. I certainly know about it from brain tumors, and there it's a cap, and I really hadn't heard about that being an issue.
Yeah, no, I think maybe
to look for that.
Yeah, I think the thinking was maybe because in the abdomen or trunk there's much more skin exposed. The head maybe not that much. I don't know. They might see it there, but actually both of these patients had a lot of problems with that. What do you think about the sort of the biologic basis for this? A lot of people kind of look at it sort of skeptically. How do you feel? We had a guy, Doc Patel. He's a neuro-oncologist. I did a whole webinar just with him trying to explain to me how this works. Any thoughts about it? Do you think this is legitimate or more hocus pocus?
No, I actually do think it's legitimate. I think in the brain especially, it makes a lot of sense if you think about everything that's happening with the signaling there. And one of the investigators at Stanford, Michelle Monge, has really done some beautiful work looking at how those the signaling, electrical signaling, can modify growth of brain tumors. I think it makes sense for other tumors that you could, with these electrical fields, change mitotic activity. That's the mechanism of how it works. And I've seen some presentations on it where it does make biological sense. I was a little skeptical at first. And I was actually at our Stanford Cancer Institute retreat recently, where some of the bioengineers were meeting with us also and kind of going through. And so, again, it's one of those things where if you just hear about it once, you're like, But if you hear about it from multiple different angles, then it starts to be something you believe is a truth, even if it wasn't a truth you would have thought of yourself. So I do believe there's something to it. Whether it's going to be a practical addition to our armamentarium in lung cancer, I don't know yet. I'm going to reserve judgment until I see the data. But I do know that for colleagues who are treating gliomas, I mean, they really do use this. It's part of the standard of care.
Yeah. The other thing they were telling me is that I never heard before was that the battery is very heavy to carry around.
That I believe, yeah.
I would imagine it must be the same kind of fields or whatever that you use for a mesothelioma.
Oh, yeah, it's the same thing.
So the entire, if anybody's using it there, I guess they would know about it.
Right, and that's why I don't know what's going to happen in lung, because we just haven't adopted it too much in meso. So.
All right, please continue.
Almost done. Just have one more study. And this is the Ipsos study. This was a phase 3 that was presented at ESMO. And this is looking at first-line atezolizumab versus single-agent chemotherapy in patients who were not eligible for chemo. And so this is the frail and the elderly, which is a patient population we don't talk as much about at trials, when we're discussing trials and when we're at the conferences. And yet this is the majority of the patients that we see in clinic when you're dealing with a non-driver patient population. So this was a pretty real-world study as far as having relatively open eligibility for patients. Any histology, not able to get platinum chemo because they had a bad performance status or because of their age. And they were randomized to either get atezolizumab, single agent, regardless of PD-L1 expression, or to get single agent vinorelbine or single agent gemcitabine. Now, in the US, we don't use a lot of single agent gemcitabine or single agent vinorelbine, but those are options that are used in a lot of the rest of the world. It's certainly a reasonable design, and they're reasonably tolerated drugs. So I can understand this design. It was, and they got it done. This was a hard trial to get completed, and they managed to. The tables here are just showing, well, who are these patients? And you can see that the median age was 75. That's one of the key things. Performance status 3 in less than 10%, but still a sizable number of the patients had a performance status of 3, vast majority performance status 2. And many of them with a smoking history or active current smoking. And when we look at the results, we can see that the response rates weren't that high. Single agent atezolizumab response rate of about 17%, which is what we would expect. I mean, that's sort of within range for single agent, 10, 20%, somewhere in there. Chemo single agent, about 10%. Again, first line single agent, single drug, that's not unexpected. What's really distinguishing, though, is that if you do respond to atezolizumab, the probability of that being a long duration response is real. And that's what leads to the overall survival benefit. So when I first heard about this trial design, I thought it was intriguing. I was a little bold, I thought, to do, and yet and I'm pretty vocal about not liking to use checkpoint inhibitors where you don't have a good biomarker to indicate response. But here, when you have a patient in front of you who you think is too frail for chemo, and your options are single agent chemo, immune checkpoint inhibitor, or not treating, this data does add a little bit more to that discussion for patients in this concept of, with immune checkpoint inhibitor, the chance of this having an impact on you is less than 20%, but it's close to that. You will have a risk of toxicity from immune checkpoint inhibitors, but you have that maybe 20% chance of long-term benefit. And with single agent chemo, you don't have that. And so it's not everyone's goals are going to be in line with, I want to try that. But I think it provides good data to have that discussion and have that be an option for patients. So that's why I wanted to talk through that one. And this is a little bit more of the information. And again, it's looking at, for this trial, the level of PD-L1 didn't seem to matter that much. So maybe the numbers are small, or it's one of those things every once in a while doesn't seem to fit the way it's supposed to when we're looking at PD-L1 levels. And we'll hear that in the adjuvant setting too when we are talking with Dr. Luis Pezares. So, and I think that was my last slide. So,
Thanks so much. It was interesting. I learned a lot as always. One final question. Are you going to be able to look at ctDNA and Empower 010?
Well, we already have. There was a presentation done a little over a year ago, and clearly showed that if the ctDNA was positive, there was a pretty robust separation of the curves, also showing that that was very dependent on level of PD-L1 expression. So if there was ctDNA detectable in a tumor that was PD-L1 positive, nice robust separation. If there was ctDNA detected and there was no PD-L1 detectable, people recurred. The problem is the assay that we were able to use, commercial assay, wasn't sensitive enough. And so even in patients who were ctDNA negative, you still had a reasonable percentage of those recurring, but there was a separation of the curve as well. And so it's sort of if you have a lot of ctDNA, atezolizumab really helps when there's PD-L1 expression. If you have a little bit of ctDNA detectable, then you're helping fewer people because there are fewer people to help, but you still are getting that benefit. We just need better assays where we can say a negative is actually negative. We're not there yet.
No, this was a tumor-informed ctDNA?
No, it was a commercial assay. It was with Signatera. But Signatera, yeah, the Signatera commercial is not quite sensitive enough yet. I mean, the work I do with Max is mostly tumor-informed at this point for the really ultra-sensitive tests. And I think that when we're dealing in the setting of adjuvant treatment, I think that we should be probably using those assays because we can get to the really, really, really sensitive results that we need. I think that when we're dealing with, and that's probably what we'll also need when we're looking at these immune checkpoint inhibitors and do we stop at 2 years or not. But for those, we might not have tissue all the time, or it's going to have been a couple years ago, and so it's going to be harder to assess.